First, let me start by saying a couple things. Thanks, Steve and Phil, for the opportunity to come back and talk to you. Thank Tom and Don for the continued support and success of this. Is really terrific. This is something like 30 plus years, 33 years. And it continues to grow and educate and try to move things forward. I'm going to show you that that might not be happening as much as we can, but it's terrific to see. I'm going to give you a perspective from two vantage points, and I want to lay that out up front as I send you the message that I'm about to send you. And by the way, I'll speak, Phil will speak, and then we'll take questions afterwards. The first perspective is this is my 29th year in this course. That's a pretty long time. Phil was talking a little earlier about turning things on a dime. I can assure you nothing has turned on a dime. The second is I now sit as a healthcare executive and managing a very large integrated healthcare delivery system in the United States with all its challenges. And I'm going to intersperse both of those perspectives. So you're going to see a perspective of living the esophagus for most of my career, and you're going to see a perspective of now living in a health system for part of my career, and I'm going to cover these objectives, which are in your syllabus and in the slides for reference, including the last one, which I think is important. We almost never talk about this at this course, but it is a fundamental principle that's going on in much of the world, and particularly in the United States right now, the thought of managing populations, and not just managing illness in populations, but as you all know now, and I hope many people in this room are actively engaged in this, managing health in populations. I just actually acquired our population health management enterprise within university hospitals, 350,000 lives across the entire spectrum from Medicaid to Medicare to all the commercial insurances. It is a very major focus in most health systems, and it, I think, is relevant to the discussion and the argument that we're having today. I want to bring that to you. Sorry, I'm going backwards here. Now, I'm going to show you two slides here, and to make the point that there are profound external forces that are shaping these arguments that we're having in this room that may or may not even be important. The first is this. I think you all are aware of the healthcare economics that are going on in the United States right now. I'm not going to show you those slides. I could do that for an hour, but I'm going to skip that and just bring it down to the individual level. And the problem is that it is costing us more. It is costing you more. It is costing our individuals more. It is costing families more. And it is costing our patients and our consumers more. And it is unsustainable cost. And the slide deck goes on to show how it impacts wages and take-home pay, and you name it, as one of the external forces that are shaping this environment. And they are powerful, and they are profound, and they will impact this field, regardless of the bickering that goes on in this room. And they are starting to. Look at this. This is healthcare costs, private health insurance costs. The blue line is hospitals. The light green line is physicians. The dark green line, which has been growing exponentially lately in particular, is prescription drugs, and then everything else down below. Interesting perspective, again, of a force that's shaping healthcare that you may not pay much attention to. I'm trying. Now, I'm going to get into reflux disease. And I'm going to show you some epidemiologic trends and then some outcomes of what's happened with reflux disease in the last 30, 40 years in the United States and around the world. In order to do that, let's set the stage. What are we talking about here? There is a reasonable consensus about what reflux disease is. Its symptoms, or organ damage, or threat to the organism. That's what it is. And it's all three, actually. And I'm going to go through all three of those. That's what we're talking about with reflux disease. How common is this in what's happened? And I don't know how many of you read these papers, but about every 5 or 6 years in a variety of journals, it started out in gastroenterology and was in American Journal of Gastroenterology, a assessment of the burden of GI diseases is published. And I'm going to show you 2 such 5-year perspectives. The first was published in 2006, and it was published again in 2012, and I think again in 2015. And here's the data from 2002. That's the 2006 paper, and the reference for the 2015 paper. And you can see some references here. The point I want to make is that it's not getting better. There's almost a 50% increase in the ambulatory visits. I'm going to show you hospitalizations in a minute. In the ambulatory visits in the United States for reflux disease. What is that? 2 million, a little under 2 million on a 5,000,005 base. That's a sizable increase in the burden of this disease in our population as measured in the ambulatory world. Some interesting perspectives I think are good to keep in mind. These are studies done in the 90s and 2000s, but almost certainly continue to be true today. No one's repeated. A lot of the things I'm going to show you, no one's repeated lately, which is kind of interesting. The emphasis seems to have fallen off a little bit. I'm not sure why that is. Here's some information about how often, if you dive into the population, people are self-medicating for reflux symptomatology. And it's rather remarkable. If you add these up, there's 22, 15, 37%, about a third of the population. A third of the entire population is self-medicating for this disease. Not exactly what I would call progress. And if you take it that one step further, fascinating study, you can see it was published in 1996, who actually dropped an endoscope down some of these patients. They're self-medicated, and many have significant disease. Undetected and unknown unless you do a little study like this. As you see patients who might walk into your office, we were talking a little bit earlier about putting a scope down everyone with GERD symptoms. Well, here's one of the rationales for why to do that. Because about half of them not only have symptoms, but will have end organ damage that could lead to something more significant and something more serious. Furthermore, good epidemiologic studies will show that reflux disease is getting worse. Getting worse as the decades have gone by. There's 1990 or so. This is the United States. There's in the mid-90s. There's in the mid-2000s. Not a curve that's going in the right direction, is it? Doesn't suggest that we're getting a handle on this disease, does it? And oh, by the way, we were all part of what we thought, what we may still think, were better therapies while this was going on. Treatment getting better. Esomeprazole was brought into the market during this. Laparoscopic fundoplication was brought into the market during this time frame. Now newer technologies are being brought into the market. We just heard one of them. This epidemiology continues. Same thing going on in Europe and the rest of the world. How about hospitalizations? Again, data that's not been repeated, needs to be repeated. It's about a decade old. It's kind of interesting it hasn't been repeated. 100%, over 100% increase in the hospitalizations for disorders caused by GERD. 216% if GERD was part of the package of the coding and hospitalizations. And I won't go through all this, but fundamentally it says that not only are more people getting hospitalized for the problem we're talking about here today, but it's more severe, and sometimes even life-threateningly severe. Now, I have a whole lot of slides that I took out of this for time purposes that talk about mortality from GERD and a lot of other things that I could embellish you with, but I won't. Suffice it to say that it is not a trivial disease by any stretch of the imagination, even if you take adenocarcinoma out of the equation. even if you take adenocarcinoma out of the equation. It's not a trivial disease. Studies would also suggest that, I think everybody in this room knows this, it is, once you have it for the rest of your life. This is the utmost chronic disease. It is as bad or worse. We talked this morning about this. I thought Joachim's talk was a great introduction to what I'm saying here. We talked this morning about how it may or may not progress. We had a little bit of debate about how it may or may not progress, but make no mistake, the data would suggest that once you get it, it doesn't go away. It's not going away. I think we all know that intuitively as we see these patients. You know that the indications for most pharmacology for GERD, even today, 2018, is episodic treatment. The FDA indications are for 6 to 8 weeks of treatment and stop. Can you believe that? There is nothing about this disease that is episodic. It's chronic, lifelong, forever, and I'm with some of the ones on the far right over there. Probably gets worse as time goes by. So let's talk about the issues. Again, Joachim laid out pretty well this morning. I'm just going to embellish it. Part of learning is repetition. Repetition is good, so I'm going to show you in a different way some of the things he said about symptom control and some of the other things on this slide. But before I do, I'm going to talk both about medicine and surgery. And the first thing I want to say is that, as you know, I'm a surgeon and spend a lot of my time taking care of patients in the surgical realm with this disease. Had terrific success. But I'll also stand up here and tell you that surgical, and I would extrapolate that to pretty much all interventional therapy today, has a meaningless impact on the overall disease. It's meaningless. There isn't enough done by any logarithmic stretch of the imagination. This is a slide I put together for Barrett's esophagus. A similar pie chart could be put together for the entirety of reflux disease. You see the very small little yellow sliver up there, which is surgical interventions. We are not impacting this disease with our interventional therapy. We're not. So I just dismiss that right out. And we can get away from the, well, I'm up here advocating surgery. It's meaningless to the epidemiology of this disease. And for the foreseeable future, it probably won't be. So how about the other treatment? We talked about this a little bit this morning too, but I want to make this observation that didn't even occur to me till about 2/3 of the way through my career, and may not have occurred to most of you. The vast majority, until just recently, maybe the last 5, 7, if you're really liberal, maybe the last 10 years, the vast majority of the data, the emphasis, the message around PPI therapy and its efficacy in reflux disease was associated with the healing of esophagitis. I find that very interesting. That happened to be, and I don't think it was by accident, by the way, I'll come back to that in a minute. That happened to be about the only thing that a PPI can do is heal esophagitis. I'll show you a little bit, maybe strictures too. It doesn't necessarily do anything for the rest of the disease process. It's an antacid. And yes, it heals esophagitis. We went through decades of information after information after information of how good it was with this, totally ignoring the fact that it's not really changing the fundamental epidemiology and problem of this disease. And you can see some of the numbers up here for the efficacy of PPI therapy for healing esophagitis. The data was there. Dr. Katz published it. Doesn't talk about it much, but published it, of how less good it was in controlling symptoms. This is a much more recognized phenomenon now than it was a few years ago, and partly it's recognized because of this guy, Peter Krillis, I shouldn't say another, but a thought leader in the world of the esophagus who started to ask this question, I think thoughtfully, how good are PPIs really at controlling symptoms? And when you get down to it, they're maybe okay. This is a paper that I've referred to you all. You should pick it up and read it because it's some of the seminal work in my mind around symptom control. And you can see for both heartburn in the circles and regurgitation in the crosses, particularly if you relate it to a placebo response, you're getting maybe a 15 to 20% benefit from the most powerful medications that we know to treat this disease. Not a great symptom control. In fact, I'll embellish you with two other things. This is a publication that Don and others put together, an AGA poll, as you can see, and it's really remarkable to look at some of the, see if I can find the pointer here, look at some of the, is it in the middle?
There it is.
Look at some of these comments here. 45% reported sleep difficulties in the month prior every night, and a third, 40% affected work habits, 34% slept in a chair. We don't talk about this very much, do we? We should, because that's the reality that the patients are seeing. In fact, we beat up on Stu a little bit this morning, but every now and then Stu has a great thought. I just wanted to embellish the fact that every now and then Stu has a great thought. He usually trips over it, picks him up, and keeps going. But every now and then he does have a great thought. And there you are, Stu. I'm going to show another one of Stu's great thoughts a little bit later. But thank you, Stu, for pointing out that PPIs aren't necessarily as good as symptom control as we thought. How about the complications of reflux disease? How are we doing in that? Well, as I mentioned, it is good in taking care of esophagitis and stricture control. And there's data that suggests that strictures are getting better and better as the decades have gone by, as PPI prescriptions have gone up. And yes, it does control the acid environment, which is primarily manifested by esophagitis and stricture. And we are making progress in that. Absolutely, no question. On the other hand, what has replaced it? And I'm not even going to get into the argument. We've had this argument, and I've been part of it in years past at this course about whether there's a relationship here. Put that aside for the moment. There is no question that this disease has also emerged and continues to emerge as a problem in this arena. It is reflux related without question. And it is a problem without question. The incidence and prevalence of Barrett's esophagus are both growing around the world in particular demographics, as you all know, and that's a problem in the management of this disease. I'm still trying to go forward here. Sorry about that. So again, here's Stu in his wisdom, who suggests that yes, Barrett's esophagus is a significant public health problem. We ought to pay attention to it, and we ought to consider what we could do about it. Esophageal adenocarcinoma. That's not a curve that suggests that we're making progress, is it? Is there anyone who doubts that esophageal adenocarcinoma is primarily related to chronic reflux? No. It's like smoking and lung cancer. They are absolutely related. Absolutely related. That curve is going the wrong way. This stops in 2005. I remember arguing at this course, Stu, I think you probably made this argument that curve is going to start to plateau or come down. Guess what? Didn't happen. Didn't happen. That was maybe 10 courses ago in that 29-year history. It didn't happen. It's still growing. A 700% increase over the course of those decades. Stu pointed out earlier that what I would call a fairly weak argument, that this occurred prior to the introduction of PPIs. Fairly weak argument. It's often thrown out, but not very strong. And I think Dr. Lebenz embellished the fact that this is projected to be, can you imagine esophageal adenocarcinoma in some high prevalence countries like the Netherlands, UK, maybe a few other places in the world, is projected to be more common than colon cancer. More common than colon cancer in the next decade or so. Problem. Not good. Not the right direction. Clearly, we're not making progress in this disease, despite the fact, as I mentioned, that we have been under the perception that our therapies are perhaps getting better. Here's PPI prescriptions, which continue to grow, by the way. This graph stops in 2004. I tried to find an earlier one, but there's so much other noise with biologics and other things that are more expensive these days that this data isn't collected as much. But this graph has also continued to grow off the roof. And I just make that point once again to point out that despite the enormity of what's going on with medical therapy, we're not changing the epidemiology of this disease. In fact, it's getting worse right in front of our eyes, and we seem to be ignoring it. Don't understand why. Now I want to dive back into health systems for a couple of minutes, and I'll finish with some new thinking, perhaps. Make no mistake, these are powerful industries. There's some interesting things going on in the world right now. These are very powerful industries. These are ginormous companies. That's, 10, 20, 30 times bigger than any health system currently exists. VA even is nowhere near some of these. These are ginormous companies. To assert that they don't have an effect on the marketplace, the thinking, and even down to our treatment, is, I think, naive. They absolutely do, and it's getting worse, because there is an enormous amount of money going on here. Why would CVS and Aetna come together? And more recently, why would a company buy a physician group like what just occurred with DaVita? United Health bought a big physician group. By and large, physician groups lose money. Why would they do that? The answer is prescriptions. It's prescriptions. United Health is about a $170 billion company. $100 billion of that, over half, is pharmacy benefits management profit. Over half. It's not an insurance company much anymore. It's a drug-pushing company. And they're making most of the money that way, and they're trying to continue that. There is a lot of money out there, a lot of money that does this. Now I want to give you another perspective. The president of our academic medical center, a guy named Dan Simon, is an academic interventional cardiologist. He has friends around the world, and one of his friends sent him this slide set. This is a national study in the world of hypertension done out of Emory, a national clinical trial, with some slides in it that I think are very telling and I think very interesting. And I'll preface at the outset that there is no such similar data for reflux disease. You got to ask yourself, why isn't there any similar data for reflux disease? This disease has been around a long time. It's easily as important as hypertension. It's almost as common, if not as common as hypertension. No such data has ever been published, not even contemplated as far as I know. They're recognizing in the world of hypertension that the issue of taking pills to control the disease is becoming a problem. It's plateauing. And it's not happening as much as it needs to happen in order to control the disease. In fact, look at the right-hand side of this slide. It points out that a big chunk of them are not adherent to antihypertensive drugs. 50% of patients become not adherent within 1 year of initiating oral drug therapy. Physicians generally tend to overestimate the patient's adherence to drug therapy. I already dismissed surgical therapy as not being relevant to this disease. Clinicians' estimates of non-adherence are very poor. Positive predicted outcome was 30%. In fact, detecting non-adherence in clinical practice is almost impossible, and you won't even believe the next slide. And I think I want to show it to you, and you got it. Show it beyond this. Up to 30% of adults would rather die early than submit to lifelong polytherapy. And of every 100 prescriptions written, and this is quite true, and the pharmaceutical industry and some of those big companies that I just pointed out there are all over this problem, because this is a big untapped market. Half of the prescriptions written are never picked up. Half of the prescriptions written in the United States are never picked up, taken properly, or refilled. That's an enormous issue. So we sit here and we debate medical therapy and you talk about it. That if you dive into the behavior of the human beings in this country, and probably many others, it tells you that you're fooling yourself. The epidemiology also tells us we're fooling ourselves. Now, you're probably sitting out there thinking, I got just a couple more slides here because I'm going to get into the think differently piece now. You're probably out there thinking, well, you know, I'm up here saying that this is a disease that's common. I told you that surgical therapy doesn't work. I told you that medical therapy doesn't work. You're saying, if you're thinking, you're saying, well, you know, I mean, okay, you know, well, give me a solution. Doesn't do any good to just complain about it. Give me a solution. Well, I'll point out two things here. And again, I would submit to you that reflux disease is no more complicated a problem, and probably less complicated of a problem, than the two I'm going to show you, where the collective community has moved the bar. And we absolutely have not, as I just showed you in reflux disease. Here's one. This is cardiovascular disease. A fascinating graph that I pulled out of the New England Journal. This was the 100th anniversary of the New England Journal, and they published a series of these this year. It's a slide that depicts the prevalence and the advances in the death rates from cardiovascular disease from 1950s all the way down into recent times, and marks the milestones. There is no such similar curve. So there's progress. Substantial progress being made in a repertoire of diseases that is at least as problematic as reflux disease is, and I'm showing you that we're not making progress. Now, that's pretty remarkable. More remarkable, cancer. Probably the hardest challenge that there is in human medicine. Progress is being made. The bars are survivors, the graphs are is death, and you pick up the lay press and you pick up the medical press, you'll find we are making progress in cancer. Substantial progress in cancer. Cardiovascular disease, progress. Cancer, progress. Gastroesophageal reflux disease, no progress. In fact, I would submit to you that our current approach to the prevention and management of reflux disease is an abstract failure. And quibbling about it in this room for 29 years, looking at it from this perspective, saddens me. Because we failed. I failed. I was a big part of a piece of this, the surgical part. And we've not made an impact here. Great technology, even better technology. We've not made an impact. Hundreds of millions of dollars spent in new companies that are sitting in the back of the room. We've not made an impact. And there are whole realms where that is not true. Despite seemingly better treatment, as I've made the point several times now, everything we know about reflux disease except for esophagitis and strictures is getting worse. Everything. Well, pretty well documented. So, you just can't solve a problem with the same thinking that created it. We've got to think outside the box. We've got to start thinking a little differently. And what occurs to me is that, unfortunately, I use the word unfortunately, the professionals that are engaged in this problem are not there, not even close. And this course is the best example of that, or a great example of that. Others are. The professionals aren't. And I'll go back to some of those external forces that I was telling you about earlier. We talked about value committees this morning. I showed you the insurance problem in the United States. You know the economic health problem in the United States. They will dive in and solve these problems. They are doing it as we speak, I can assure you. I'll just give you a couple of examples. How many of you saw this? Raise your hand. Amazing. This is billions and billions of money, and over something like 1.2 million employees each coming together to influence healthcare. This is the employer sector of our economy coming together and saying, we're tired of this nonsense. We're tired of this nonsense. You haven't solved it. The insurance companies haven't solved it. The pharmaceutical industry haven't solved it. The professionals haven't solved it. And it's costing us a fortune, and we're tired of it. So guess what? We're jumping into the game, guys. And some pretty powerful forces are jumping into the game. This was just published. Not peer-reviewed, but fascinating data. This is now. This is today. It's happening more and more. Most of you probably are aware of this kind of thing. Google just published that with 46 billion data points and 2 large academic medical center electronic medical records, that using predictive analytics and machine learning and AI, they can predict death in a hospital and many other things, if you read this paper, better than anything that's ever been discovered to date. Any predictive paper that anybody's ever published, better than anything that's ever been discovered to date. That is happening in our world today, and will become only more and more. We're about to start hiring AI individuals into our IT department. Health systems are beginning to do this more and more. And I'll just finish with this. How many of you saw this in the New York Times? Anybody? One. It was very interesting. It was an interesting observation. This was a little story about an interview between these two individuals. You all know who Bill Gates is. Steven Pinker is a Harvard psychologist who tends to think outside the box and understand human behavior and other things. And I was reading this. It was fascinating in many ways, but I was reading it, and about 2/3 of the way through, there was this quote. Nothing could be more true. The conversations we've had this morning embellish that this is absolute fact. Nothing could be more true. Unfortunately, after 29 years, I'm tired of it. We got to get past it. We got to make progress in this disease. We got to start doing something that really makes a difference. So one of the things I did was I moved, changed my career. This is a typical summer in Rochester. This is a typical summer in Cleveland. So I got out from underneath it. I enjoy it very much. And now I'll let Phil tell us what he can accomplish.